very, very eager to do smile makeovers, to do veneers, to do cosmetic cases, to do rehabs. I was keen. I was keen because I wasn't doing very many. Now, I do them all the time. It doesn't matter to me whether I do one or not. Every single week there's 1 or 2 booked in. And so part of that internal psychology is that when you're keen, you don't worry as much about whether the patient is also keen. There's a couple red flags about this patient. One was she was always going, oh, maybe I want to do it, maybe I don't. And I kept trying to talk her into it. If you have to talk a patient into a smile makeover, into any sort of significant dentistry, you probably shouldn't be doing it. I know there's a whole bunch of courses that teach you to convince the patient, to talk them in, to help the patient choose to do the dentistry, but sometimes you can be too good at selling. If you sell beyond your ability to deliver, then you will get into a lot of trouble. And if you sell patients beyond what they really wanted, you'll get yourself into a lot of trouble. So we went through. Now, the photos are not very good because this is a case I did years ago, but same sorts of processes that we do now. We did a mock-up, okay, we prepped. Now, here's where it started to go wrong. When the crowns came back, I didn't really like them. Okay? They weren't really the right colour, they were longer. Now, the most common mistake that technicians make with any sort of aesthetic work is to make the crowns longer. And I'll talk about why that happens a little bit later on. They were too long, we didn't really like the colour. And because I'd tried to compensate for the underlying tooth colour, I had made the ceramic a little bit lighter than we'd planned. That's normally something we leave to the technician, but I'd made that thing. And in my eagerness to explain the process, I told the patient, well, suddenly she was fixated. So much so that within a week she's going, Lincoln, I don't like them. So this is a week after I'd put them in. Here we are drawing lines on the teeth. This is how much we've got to cut off. So we cut some off, we reshape it, okay, and then a week after that I'm cutting all the ceramic off. I did new set of temporaries, we reshaped them, and then I started making a new set of crowns. So these e.max crowns had only been in for a week before we were cutting them up, and 2 weeks later we were cutting them all off. So it was the first time I'd cut off 8 e.max crowns, and it was certainly the first time I'd cut off 8 that I'd done. So now we start getting the new crowns back, and we like the length better, but start looking at the problem. Now all of a sudden we've changed the ceramic to have try and make it not so bright, but now it's gone blue. This was when, it was still early days of e.max when we were doing this. It was quite a long time ago. So now the e.max was too translucent, so it was coming out blue. Here I am taking pictures for the technician. The technician would come down. Here we were trying on all sorts of different shades, try and get it, and we finally ended up with this. Very white teeth. The patient was relatively happy with the shape and so on, and she came back a little bit later, and maybe a year later for her next checkup, and she says, I don't really like them. Now here's the problem. The problem was that when I looked at them, I didn't like them either. I want you to think about that. If you think the work is sensational and the patient approves the work, and then later on the patient says, I don't like it, then that's the patient's problem. But if the patient says, I approve the work, but you look at it and go, oh, I don't really like it, I don't think I should put it in, but I don't want my hourly rate to go down, and I don't want to send it back to the lab and annoy the patient, and the patient's driven 2 hours to see me. Or in one case I did where I really don't like the result, the patient flew 4 hours to see me. She lived 800 kilometres away. So that problem is that if you don't like it and the patient changes their mind in 6 months or 3 months and says, you know what, I really don't like it, and you look at it and you go, yeah, I don't like it either. It's a redo. It doesn't matter whether you've signed papers, whether you've had guarantees, it doesn't matter, it's a redo. Don't fight with your patient, you'll never win. So that's number one. Here's a patient here. Now, she came back and she said later on, everyone looks at my teeth all the time. So I now have a few rules about this. The first one is, with my more mature patients, if they want really white teeth, like bleaching shade teeth, normally I will try and talk them out of it. I'll tell them, people will look at your teeth all the time. Most people like to have their teeth so nice that you think their smile is beautiful, but not so that you look at it all the time. If someone came up to you, if every single day people looked at you and went, wow, your eyes are so blue, you know, so bright blue, all of the time, you would start to get quite self-conscious about your eyes. So mostly when people look good, we go, yeah, they look good, but we don't actually say to them, wow, you know, it's unusual for us to say, wow, your nose looks good, or, you know, wow, what have you done with your nose? What a great job you've had. We would feel self-conscious if that happened all the time. And so this is what happened with this lady. I had several other ladies of similar age who had bleaching shade teeth, and all of them, 1, 2 or 3 years later, came back and said, they're too white. I wish I hadn't got them so white. People look at them and comment on them all the time. So that's just a little tip, is whiteness. But the most important point there was, if you don't like it, don't put it in. Okay. So where I get the most problems, okay, we've got all this list. The least problems I get is with technique. Okay, the actual how I do preps, how I take impressions, how I take photos, that area is where I get the least problems for a smile makeover. Where I get the most problems is for certain at the consent process, the approval process, and the insertion process. Now, the insertion process is not because insertion is difficult, it's because we have to master ourselves. So no matter how long we've booked, how keen we are, if we don't like it, we don't put it in. Now, when we want to, we need to get inside the patient's head. We need to understand, you know, what are they trying to achieve by this large-scale dentistry? What is it that they want out of this? We need to almost try and learn to see what they're seeing, okay? And that's quite difficult because we're dentists and we don't see teeth the way patients see it. This lady came in and she says, I hate it when people get veneers. I hate the look of it. I hate it when their teeth look done. She says, I want my teeth a bit straighter. I want the recession fixed, but I don't want my teeth to look done. Okay, so very specific requests there. Now, how do we get to that? One, I've known this patient for 18 years, so that was a lot easier. We've got very good communication going on. But if it wasn't someone I'd known, it's time. If you rush your consultations, you won't be able to get into the patient's head. You won't be able to understand what do they want, how natural, how fake. Because a lot of times people come in and they say, I want natural looking teeth. And you go, tell me about natural. And they go, I want them all flat with none of those little gaps between it. And I want it flat on the front and shiny and, you know, white as anything. And you go, well, that's really fake to yourself, inside voice. But if you rushed the appointment and the patient said, I want natural looking teeth, and you gave them A2 with texture and some chipping, which is what natural looking teeth, in fact, probably just like the teeth they already have, then their term natural looking teeth wouldn't match with yours. So that is like a huge area to get problems. So when we're talking about goals, one of the things we want to know is naturalness. You know, I have patients who want teeth that really, they want them very fake. That's their idea of teeth, is that teeth are very white and very flat and very opaque. And then I have patients who want teeth, they want their teeth nice, but they want them to look like they haven't been done. And it's actually much more difficult. You know, we're using different materials, we're using more colours, we're using more warmth, we're using much more texture. In fact, we're using a lot more ceramic skill if we're doing ceramics, or dentist skill if we're doing composite resin. This lady came in because she had a chip, okay, but she says, I don't like my veneers. I want my veneers to look nicer. She had a type of veneer that was just a no-prep veneer stuck on. It was very popular a few years ago. But she didn't like them because everything hadn't been planned properly. Now, she didn't really know why she didn't like her smile. She just knew she didn't like it. And in that particular case, I had to go through a planning process, which I'll show you later, to determine that she was showing too much gum and her teeth were, the incisal edges of her teeth were too long and the gingival height was too short. So we had to move the gingiva up and also move the incisal edge up on some teeth. This patient came in to me and she'd had orthodontics and she says, my teeth, I've had orthodontics, I'm not happy. I said, why aren't you happy? She says, I'm not quite sure. I just don't think it looks nice. So these sort of cases are ones where we need to give professional guidance. So the patient can't just tell us what the issue is. We actually need to slow down. Like, it would be very easy for the first patient for me to just go, okay, you don't like your veneers, I'll do new ones. But they're the cases where we must slow down and actually guide the patient, go, maybe it doesn't look good because your gum's a bit low. And the way I do that is, whilst I'm sitting there consulting with the patient, I will put the photo of their smile up on a massive screen. It's a 60-inch screen attached to my computer, so what I'm seeing, they're seeing. And I might do a little bit of smile design to start giving them the idea of where the gum height should be. Or why the lady who didn't like the result after orthodontics, why she didn't like it? Because the whole arch, she'd had extractions and the whole arch was narrowed. So she was a vivacious personality with this constricted maxilla. Not broad enough teeth really for the way she portrayed herself. And then one of the most important is whiteness. Okay, now this one, I have more troubles. When people say I want white teeth, that is one of the most difficult things. These teeth I don't like at all. Okay, they are definitely bleaching shade. The patient wanted them really, really white. Okay, and he's got quite a tan complexion, so they look really white. Okay, they don't, in my opinion, they don't suit him at all. He works outdoors. He's a big belly bloke. But he wants very white teeth. So when we're in that consulting phase, the whiteness of teeth is a huge. When people say I want whiter teeth, what does that mean? This lady, she said, I don't want my teeth to look done. So that's quite often the extremes. I want nicer teeth that don't look done. They don't look like they've had dentistry. Or I want nicer teeth that really look quite spectacular because they're definitely done. So these are some of the things that I really want to understand when I'm doing the goals of the patient is, what do they mean by natural? What do they mean by white? And when they say I don't like it, what do they mean? And sometimes to guide them through that. Obviously, planning is one of those things where the more time we spend on it, the less time we spend fixing things later. Now, when I started doing a lot of these smile makeovers, the digital design process that we use now hadn't really been invented 8, 10, 15 years ago. And so a lot of time was spent, I would draw pictures and send it to the lab, but the wax-ups were never very accurate. But you could still correct them because you would do a mock-up or you would do temporaries and you would correct it. Now, obviously, even to this day, when we have very precise wax-ups taken off digital designs, even to this day, I always check the mock-up or the temporaries, and I would never go from a start to a finish without checking the temporaries or having some type of process to check that the patient is happy. And in particular, to check how it looks when the patient is not anaesthetised. This is our big problem, of course, is that every time we're seeing the patient, they're usually numb and their lip doesn't work and we can't see what the smile looks like. We can't see what it looks like when their head is straight and when their lips are high. Just a few little planning things that I've gone through. So this is once again that patient who didn't want her teeth to look done. We can see that immediately the issue is crowding. There are some issues with crowding here. Obviously, when we start looking at the crowding, we start looking at the recession, and she had sensitive areas in the recession. So now our smile design thing starts getting confused or combined with functional issues, health issues, and order issues. Which do we fix first? Obviously, any type of orthodontics that pushes the teeth out, you should graft first, and anything that's going in, you should graft after the orthodontics. So here's just part of the planning. We're going, okay, what is the main issues here? We want to straighten the teeth, but because we're going to expand the teeth out, if we expand them out and she's already got recession in these areas, then we're going to end up with the recession getting worse. So it's an expansion type orthodontics. And that's because when you retract teeth in, often the gingiva may actually end up covering some of the recession anyway, or it's certainly not likely to get worse unless you retract them right in and then out the lingual plate. But in this case, we're trying to expand out, so we'd expect the recession to get worse. Also, one of the things she hates is this black metal collar. And so this is where we can start to break procedures down. Just because we're doing a smile makeover or we're doing a big cosmetic case doesn't mean that we have to do everything all at once. Sometimes, if there's one issue that really bothers the patient, we can do that small thing first and then do the rest later. Now, I've heard people say, oh, but if I take away that small problem, then they won't want to go ahead. Well, that's great. If you solve the problem with a small thing, your job is not to try and force patients into large-scale dentistry that they don't want. So in this particular case, this lady was quite anxious. And so we wanted to test out, could she cope with large appointments or not? So we decided the one way to find this out would be to do one small bit of procedure and see how she coped. So we took the crown off, did a new core, and then did a temporary. So that took away one of her major issues. She had this problem with the crown showing, and we did that as a quick fix while we were planning the rest of the treatment. She goes, that appointment sucked, I hated it. So the moment we started getting into the large-scale treatment, then we immediately knew we'd need sedation, and we had an IV sedationist for the 3 hours it took to do the gum grafting. So when we're doing this planning process, we really want to ask ourselves some important questions. One, can it be done without orthodontics? Now, all of us have, these are not, cases never black or white. Okay, yes, there are cases where absolutely you cannot do them without orthodontics. We know that everyone can look at it and go, you know, those teeth are so crooked, you would get dizzy trying to prep them, okay, because you'd be prepping so many different angles. But there are cases where they're kind of straight enough, you think, if I do orthodontics, I'm probably going to do veneers anyway, I could just do it all in one procedure. So they're the ones that are difficult, where we're in the grey zone. And then you've got the cases, can we do it without surgery? So can we do this case without crown lengthening or not? Can it be done without implants? So when we start going, can we do this case without all the adjunctive procedures? Then we sometimes have to go to the mock-up or the consent stage. So, but in general, if you should have your lines in the sand. I won't do endodontics just to straighten teeth. So that's my line in the sand. I won't cut into your pulp. If preferable, I won't cut into dentine just to straighten teeth. And I will just tell the patient, no, you need orthodontics. And quite often I hear people say, the patient didn't want orthodontics. I had to do really heavy crowns because the patient didn't want orthodontics. No patient wants orthodontics. But if you tell a patient, we will severely damage your teeth if we don't do it. If we do this case without orthodontics, it's a bad idea. And you have conviction, then it's surprising how many will go, okay, we'll do the orthodontics. Of course, I have this conviction because in my youth, I did some cases that should have had orthodontics and I did them with ceramic. And one, they never looked that great. And two, when you've got big crowns on off-axis roots, you often get mobility. And three, every time you look at that case or think about another dentist looking at that case for the rest of your life, you're going to feel awful. So for me, it is not difficult to have that conviction because it comes from the mistakes or the things that I've done wrong in the past. So here's some planning. This is that lady I showed you earlier where she wanted nicer veneers. Just going through, just step by step, very simple to do this. So in her case, obviously I straighten the eyes. People do all sorts of things where they put one image over the other and they make it 50% translucent and then they try and, I don't do that. I just get the eyes straight and then I draw a line between 2 points in the smile that you'll be able to see with the retractors on that is very distinctive. So in this case, I've chosen the top of 2 teeth and then I can copy that line and paste it over the top of a close-up smile. And I've picked the tops of the 2 canines, so you can see the left and right canine, the line is sitting on it. So I can angle the photo until the gingival heights sit on that line. And then I can obviously draw it in. And it becomes very simple. So we can start to get very precise guides. Now, you can draw, I've seen people get little rulers and place them over all these images so that it's exact how many millimetres you're going to get the wax up. Or, here's a better idea, train the technician to do that, because the technician can calibrate, they can print this image out and they can calibrate their ruler, just the one that sits on the bench, to the size of the model and the size of the printed image, and then they can do all those calculations themselves. It's not very complicated maths. So another case, this particular case, what we were really wanting to know is, could we do this case without implants and without soft tissue grafts and without orthodontics? So would it look good just to close all these gaps with restorative dentistry? So then we go through that planning process, and we're trying to get our diagnostic wax-ups or our processes much more accurate or much more precise. Now, when we get to the consent process, consent, I have learned, makes your patients happier. It is not there to cover your bum. It is there to do that as well. It's there to avoid lawsuits, but mostly it is to make your patients happier. One of the things that I've learned is that when you do a really good consent process, the patients end up happier with the work. Okay? It's not as easy to sell because you're telling them all the complications that could go on. You're telling them that you're lowering their expectations. You're not telling them that they're getting a lifetime guarantee, but in fact it will wear out and they will need to repair it and so on. But you're making them realistic. So in your early years, early in your career, you will find it very difficult to do proper consent because one, you're not sure if your work's actually any good. Two, you're not sure how long your work will last, so you tend to overpromise, oh yes, it will last the rest of your life. Of course, when you're 25, you think the rest of your life is until you're 35, okay? But when you get to 40, then you start to realise that all your patients are going to live till 80 or 90 or however long. I have a lot of patients who are in their 90s that I started seeing when I opened the practice 19 years ago. So all of my work that I did back then is all starting to fail, and only the death of the patient will make my work last a lifetime. This particular patient came in just this week, and she came in, and the first thing I see is that her grey margins on her crowns are like stabbing me in the eye, okay? I'm sitting there trying to look at her, and it's almost like she needs to go, hey, Lincoln, my eyes are up here because you keep looking at my teeth. So the grey margins are driving me crazy, but she doesn't care about them. I go, do you care about that? And she goes, I'm not that worried about the look of my teeth. So when someone says, I'm not that worried, they're still a bit worried, but not that worried. So I'm not going to push her. I can guarantee you that within 3 or 4 years, we'll be replacing those crowns with something that looks much better. And she will love the fact that they look better, but she will never admit it. Okay? How do we consent to that? We give her time, a lot of time in this case. I'm quite busy, so it doesn't make any difference to me. And how did I get busy? By doing this process. So by making sure I did the best for every single patient, even if it took much, much longer, has led to the point where we're booked a long way ahead. So the patient had great things going on there, but when we had a bit more of a chat, I said, what's the concern? She said, I'm really worried about my gums receding. Well, that's great. See, she's worried about the function, she's worried about the health, and in the process of fixing that health and function, we're actually going to make it look better, and we're going to make it much easier to do nice looking crowns because we'll have better gum tissue. I said to her, is it something you're keen to do? She says, oh, maybe I'll do it later in the year or early next year. I've got some travelling to do. So I'm fine with that because I know that if she goes and thinks about it for a year, her frame of mind when she comes to do it will be much more motivated. She will be actually wanting to do the treatment, whereas right now she's not quite there. I could talk her into it. I go, oh, you know, if you don't get it done, it's going to get much worse and it'll be hard for me and you might lose your teeth. And some of that might be true, some of it might not be, I don't know. But by pushing her into it now, if she gets any complication or anything is a little bit uncomfortable or one of the sutures pulls or have to redo something, she's not going to be happy. So people need time to consent. And if you give people time, you're not pushing them, you're not rushing them, you're not trying to get them to make a decision before they change their mind. If you give people time, your treatment plans will get bigger. Your acceptance rate will get higher. Okay? Your patients will be happier. Future costs. I like to talk about the future costs. I did not used to do this, and then I had to pay for all the future costs. I used to give guarantees, okay? I'd give a 5-year guarantee, and possibly that was appropriate earlier in my career because I wasn't actually that good, and so I used to make a lot of mistakes, and so I kind of had to fix them, and it was good to have a 5-year cut-off, say, okay, you passed the 5 years now, I don't have to pay to fix my work anymore. So 5-year guarantees are more for the dentist than they are for the patient. But future costs with smile makeovers, you know, if you do a whole bunch of veneers, they're going to chip one eventually. Even if you, look, even the teeth that God made chip, okay? So obviously some dentists think they're God, but not everyone. But the future costs, you know, chipping your veneers, recessions, crowding, things like this, once they get it done, it's not the end of the road. If they're 40 and they're doing veneers, they're probably going to redo them when they're 55 or 60. They may as well know that now. And so then they're realistic. When they do fail, they won't go, oh, that's terrible. They failed and they should never have failed. They're going to go, that's what I expected. And then if they don't fail, they go, oh, Lincoln said it's only going to last 10 or 15 years and then I'll have to redo it all. And actually, look, it's lasting much longer. Failure, I've heard different views. Some people say in their country you can't talk about failure because it puts the patient off. If that's true for your culture, then do what you have to do. I like to talk about things that can go wrong because sometimes they do. I'll give you an example. When I do implant dentistry, one of the risks of implant dentistry is that a patient could swallow one of the drivers or one of the screws or something. We're handling a lot of little, no matter, I put floss on all the ones I can, but there's so many things that they could swallow if they flicked it with their tongue. Now, I've only ever had one patient swallow a driver doing implant dentistry. But the stress, the distress, he went around telling people I nearly killed him, okay? Very bad for my reputation. That's not because that's not something that can happen. We know that any patient, it was his fault. He flicked it with his tongue and then he swallowed it. But the issue was he never knew that that was a possibility. And when he had to have an endoscopy or colonoscopy to fish the driver out of his bowels where it had got lodged, you know, that's when he started saying, the dentist nearly killed me. So for me, things that can go wrong, I prefer to get out of the way. Now, super important, you must stamp out passive aggressiveness. This is the patient who doesn't want to tell you what they're thinking because they don't want to go, I think the veneers are too white, they're too long, they're too tilted, I don't like them, because they don't want to hurt your feelings, they don't want to make you sad, but then they slowly brew up. Okay, they get a little bit more aggressive each time and then suddenly there's an explosion. They go, I don't like them, you never, and then there's all, you know, absolutes, you never, always, this type of thing. So the way I stamp out passive aggressiveness, and this is probably the second most important thing I will teach you in this webinar, is you tell the patient at the very first visit, if you do not like the veneers, tell me. Tell me and I will fix them. If you don't tell me you don't like them and you agree to have them inserted, agree to have them bonded, glued, cemented in, and then you change your mind, I will charge you the full fee to do them again. Now here's the thing, I probably wouldn't, okay? You'd probably not have a leg to stand on if the patient didn't like it, okay? But what that does is it stamps out passive aggressive. First of all, you've given the patient permission to tell you that they don't like something if they don't like it. Secondly, you've actually threatened them. If they don't like it and they don't tell you, then they're in big trouble. And thirdly, there's a part of it which is that you have to be willing, if they don't like something, to fix it. Now, let's have a little bit of a look in this consent process and how it might work. So this patient, what he wanted is he wanted to see, could he get his gaps closed? So could we make his teeth look decent closing the gaps? Because obviously closing those gaps is going to make his front teeth very big, and he didn't really want to get an implant in the gap if possible. He wanted to just get a bridge done or something a lot quicker and easier because the cost of this treatment was reaching the end of his limit. So during the mock-up process, we're able to show him photos of his teeth and we go, this is what you look like if we close your gaps, this is what you look like if we put a bridge in without doing a soft tissue graft to bulk the tissues up. Are you happy with that? And he could look at those photos and go, yes. So that's a consent process. We've allowed the patient to see what might happen, and then we can check that. Here's another patient where we're going, okay, we want to add some length onto your teeth. He's hated his teeth for a really long time, terrified of the dentist. He's 60-something, finally wants to get his teeth fixed before he retires because he knows his income's going to go down after he retires. So we can do a mock-up. I think they're a little bit long. I show him, he just thinks it's terrific. See, so sometimes big changes like length, we can get an idea what the patient is thinking, what we're thinking, well before we do anything irreversible. And this particular patient, now here we learnt that her previous veneers are so bulky, we can't do a mock-up over them. They're massively bulky. When we tried to do a mock-up over them, and the mock-up wouldn't seat, it was hanging down low, and we had to actually draw lines to show how much we would shorten the teeth because her teeth just looked so long. Now, lab communication, we all know about things like shades, stump shades, things like that. They are almost never the things that cause major problems. In my experience, the two killers with large-scale restorative work is a cant. So the patient, the technician held your model, said it looks good like this, nice and straight, not realising that the patient has a maxillary cant, builds everything with the model straight with the floor, you put it in, now the patient's got a cant, a big cant, okay? They look awful. So, shades we know about, stump shades we know about, face bows we know about. Making sure we have an occlusal plane, that's absolutely key. So any case where we've got we're doing the whole anterior segment, we need to have more than one reference to give us a horizontal. I'll talk about how we use the length of the temporaries. This is a super important tip, okay? And adjusted temporary impressions are pretty standard. People all do them, textures, polishes and stuff like that. Okay, now most of us when we're doing a big case, hopefully, we'll be using a face bow. The face bow we're using for occlusal reasons, but we're also using it to give ourselves a plane, a horizontal. The problem is that when you put face bows in the patient's ears or on their nose and you're tightening things, it's not easy to see if the face bow isn't tilted slightly. And very, very occasionally you'll get people whose ears are actually canted. It's very rare, but it can happen. I've had a few patients like that where the ear canals actually were canted, and so when I got the face bow straight on their ears, it made everything else off. The cant has ruined more cases. Length and cant have ruined so many cases for me. Quite often I will do a secondary plane. So, I mean, if you've got a Cois dentofacial analyzer, that will do all of this for you. It'll give you a horizontal, it'll give you a vertical. If you don't have something, you can use anything to give you a horizontal plane, but you must have a photo so the technician can see it. You can use a bamboo skewer if you want to. You can use a piece of straight metal. I don't care what it is. I just put some bite registration on the front teeth. I get the patient's head straight by looking at their eyes, and then I hold this and get it straight with their eyes as best I can, and then I go back and take a photo so that the technician can see if I've still got a very tiny cant in this. So one way or the other, have a secondary plane for anything that's the entire smile. In some cases, I will also even take a picture of the preps with retractors so that the technician can see if there's a major cant with the patient's eyes. So number one problem I've had is cants. Number two, when you send, most of us what we do is we send an impression of the temporaries or the wax up or something like that to the technician, and the technician tries to copy it into the ceramic. And mostly what they do is they get a model or they get the wax up and they seat that against the opposing teeth, and they take a little silicone jig of the edge of the teeth. What happens though is that quite often they end up with a small discrepancy, and somehow the teeth get 1 millimetre longer. Many, many cases have I seen come back and the teeth are 1 millimetre longer than I wanted. And this is not from bad technicians, this is from really good technicians, okay? It's to do with the process of the lab from a whole range of things, from like how the models fit together, adjusting the models, occlusal discrepancies, the stiffness of the silicone that they use to do that incisal jig, which can hold up the models. So you've got all of these things going on, and it's very easy for the teeth to get 1 millimetre longer. So there's two things you can do. The first is you can measure from incisal edge to from gingival margin to gingival margin on certain places around the arch that you can reach with calipers, and write that measurement down. That will also help the technician realise if the bite is off. So if you measure from the upper first premolar to the lower first premolar, upper second premolar to the lower second, and some front teeth, and you get those measurements to 1/10 or 100th of a mil, and write them down. The technician can measure those when he's got the models mounted. And if there's a big discrepancy, he knows that there's an error. The second thing, and this is even more important, write this one down, please. Measure, if you've got the temporaries perfect, you've got the mock-up perfect, it's been adjusted and the patient loves it, go and measure every tooth from the incisal edge to the gingival margin. So measure the canine, the lateral, the central, the central, the lateral, the canine. Write those measurements down and send them to the technician, and tell the technician, do not change the length of the teeth, no matter what it looks like in the lab. The only time you have to be careful is if you've made your preps subgingival. So if your preps are 1 millimetre subgingival, then you might need to add a little bit on, okay? So that's kind of tricky to work out. But I have found giving the technician the exact length of the teeth really helps stop the technician getting can't. Because even if they can't the model, when they add all the lengths up, they're going to realise that the smile goes like this. So it has saved me a lot of cases. And when I get lazy and don't do things like this, I regret it. So we measure all those lengths and we send them to the technician. Now, where do things go wrong? This is the single biggest mistake I've ever made. And I made it with that one that I showed you at the start. Anxious people often get smile makeovers. People with depression often get smile makeovers. You can't treat depression with restorative dentistry. So firstly, if they're on any sort of antidepressants, I would always make sure that they're stable, they haven't changed the medications recently, they haven't been on the medications for a short time, they've been on it for a long time, that type of thing. So no unstable depression, because you will never fix depression with a smile makeover. No sedation at insert. Never, ever, ever. If you sedate the patient when you put the veneers, the ceramics, whatever in, and the patient approves them, they can't consent to anything. They won't even remember it half the time. It depends. Even if you use an anxiolytic, I use lorazepam. So lorazepam is the anxiolytic I give a lot of patients for a lot of procedures, just to make them chill, because it makes my life easier too. They're relaxed and sleepy. Never, ever, ever at the insert. They can't approve it. They can't like the colour. They don't like the length. It doesn't matter if they do, because you can't consent under the influence of any sort of sedative. So that is my single biggest tip. Never ever insert anything under sedation. Now remember the passive aggressiveness. Now we get to things like, remember these teeth are like super white, I don't like them. So I can't actually tell a patient whether they look good or not, because I don't really like them. Patient loves them. Now we get to the point where you go, okay, are you sure you like them? And we've got to stamp out passive aggressiveness. This is where the patient wants to get out of your chair because they're sick of being in the dentist chair. They're anxious, they want to leave, so they're going, yeah, they look great, they look terrific, I love them. And then they get home and their husband or wife or friend says, wow, your teeth are so white, wow. Okay, and then they come in the next day and say, my friend. You go, well, why wasn't your friend here? Okay, why are you worrying about your friend? They come in, my friend said they're too white. Okay, when someone says my friend, it just means they think it's too white and they want to blame their friend because it's easier. So we have to stamp it out. So this patient, he says, I really like him. I said, are you sure? He says, yes. I took some photos. Don't show them a mirror. You can't see yourself in a mirror. I took photos. I took full face photo. Took smile photos. Okay, I took retracted photos. I took occlusal photos. I took all sorts of photos and I showed him all of them. What do you think? Now notice that he can actually smile there, but he can't smile full height. So he is numb. He has been anaesthetised. So he can't do full smile. But this particular case was even more stressful and I wanted the patient to be able to smile. So we can do palatal infiltrations halfway between the gingival margin and the middle of the palate. And if we do those, we can anaesthetise all the front teeth and the patient can still smile. Now, how do you try veneers in? You can't always try veneers. That's why measuring lengths and all of that sort of thing is so important, because you can't always try veneers in. Sometimes, I had some recently, even with the rubber dam on, I couldn't get them to sit on the teeth, they just fell off. If I hadn't had rubber dam, the patient would have swallowed half the veneers for sure. But this particular case, I was sitting them on, the veneers were sitting pretty steady, so we put glycerin on all the veneers. Glycerin really helps the veneers stick to the prep enough for the patient to stand up and take a photo. This particular patient actually stood up and we took full face pictures. I said, what do you think of the veneers? And she said, you know what, I really like them, and great, we put them in. Okay, so if you do want to do a try-in, for sure, you need to do palatal infiltrations, not buccal, otherwise the patient can't smile, and use glycerin. What type of glycerin do I use? KY jelly, so personal lubricant is the cheapest. Most of the time you're going to have to do something like this. The patient comes in, you can't try stuff in because you're worried about it falling off, so you're going to measure the temporaries, then you're going to measure the restoration and make sure the lengths are the same. If the lengths are the same all the way along and the shapes look the same on the model as they do in the temporaries, then you're as close as you can get. So this is how we double check. Yes, all my calipers were rusty at the time. Next thing is, so rule number 1, patient can never have anything inserted. They can't approve anything if they're sedated, so they can never be sedated. Or if they are, they have to take that risk and sign it away, and you explain all the costs if they wake up from sedation and don't like it. So that's on the patient's behalf. The second thing is the discipline over yourself. So I have made, besides the patient approval issue, the second biggest mistake I've made is putting in work that I don't like. Why do we put in work that we don't like? We put it in because, one, we're worried about annoying the patient. We're worried about our hourly rates going down. We've booked like a 4-hour appointment and we're half an hour into it and we realise that the work's no good and we really need to send it back. The time pressure, the waste of that time is really weighing on us. And the temptation is, and I'm not judging you if you've done this, because I've definitely done it and cut it off. The pressure to put stuff in can be enormous. And so this is a case this week. I put it in, I thought that looks awful. It's nothing like what I planned. I don't know what happened. I think one of the impressions, one of the little customised impression copings hadn't gone to the I'm not sure. Anyway, so we put it in, we go, no, it doesn't look good. We draw pictures, okay. We take a whole bunch of photos. Whatever we need to do, and we also adjusted the occlusion on a whole bunch of these teeth, and then we sent it back. Now, in this case, I planned it, but I want you to know that there's a lot of cases where I bring the patient in to insert stuff, everything's ready to go, and I go, no, I don't like it, it's going back. Okay, and what that results in is that I never put in work I don't like, which means if the patient comes back and says, I approved it last week, but now I don't like it, I look at it and go, well, I do. So you shouldn't have said you liked it. Okay. Just some things that we go through when we're trying to try stuff in. So this is the golden rule. If you do not like the work, don't put it in. I don't mean like if you don't like the colour. If the patient wants white teeth, and okay. But if you look at it, it's not like the temporaries. It's not like we planned. It hasn't worked out the way I would like. So that's probably the key things that you can do to have perfect smile makeovers and the big errors to avoid. Okay, I know that we want to focus on how do you prep and how do you put retraction cord and how you do impressions, but they are not where the errors are made. They're not where the costs come in, the cost of cutting stuff off, the heartache, okay, or the disappointment, or and you might think, well, you know, why does the technician sometimes make mistakes? When I started going to the lab a lot, and what I noticed is that in the lab, everything looks terrific. I had a denture case today, just 3 teeth. I look at it on the model, it looks amazing. I put it in the mouth, it looks awful. I put it back on the model, it looks amazing. I'm going, I can hardly see what's wrong with it. And then I put it in the mouth, the teeth are too long. But on the model, they look fine, because the way you tip the model, you can change so much. Your crowns that don't fit look good in the model, but the moment you try them in the mouth, they don't fit. Things that look, you think, oh, the shape of that implant crown is nice. You put it in the mouth, it's awful. So the poor technician is dealing with something that is very forgiving, and we're dealing in the mouth, which is very unforgiving. Okay, now, they're the key things I really want to help you with, so hopefully that has been really useful for you. Now I'm going to take some questions, so if you've got questions, please send them into the chat line, they will come through to me. I'll grab some of those now. And just while I'm waiting for the questions to come through, we've now got a 12-hour lecture covering all the facets of the technical side of anterior dentistry, of cosmetics, the perfect smile makeovers. So that is coming out at the end of June. If you want to pre-order now, you'll get 55% off. But more importantly than what you'll save if you pre-order now is you only need to save yourself redoing 1 or 2 cases and you've massively paid for it, okay? If all you do is not have to send 1 crown back or cut, hopefully you never have to cut 8 e.max off a week after you do them, like I have, more than once. But if all you can save yourself is just 1 or 2 cases, it's well and truly paid for itself. Now, if you have questions, please send them in. More questions, the merrier. Oh, there is a lot of questions. Okay, this is from Damien. When you send a patient home with provisionals for getting used to them, do you bond them permanently? I think what they mean is a mock-up. If you do a mock-up over the teeth and you're sending them home for the patient to try out for a while, do you bond them permanently? I wouldn't bond them permanently, but I would bond them. It depends how long. If it was 2 or 3 weeks, maybe I'd just use self-etching primer. I wouldn't etch the enamel. I wouldn't sandblast the enamel. I would just use self-etching primer and bond. And I have used self-etching primer and bond to help hold temporary veneers on, like covered the whole prep with self-etching primer and bonding agent. I can get self-etching bond and primer off if I haven't sandblasted the enamel and etched the enamel. So it would depend on how retentive the mock-up is. It would depend on the patient. It would depend on their occlusion. If they've got massively worn teeth and they've got massive masseters, then yes. I had a case recently where the patient I showed you with the really white teeth, I cemented his lower temporary. Recently he broke the temporaries like 2 or 3 times. He's a massive parafunctioner. I have cemented his lower temporaries with Fuji Sem, which is a permanent cement, which means I'll have to cut them off because he keeps breaking and dislodging and chipping and all sorts of things too often. So the answer to that is it would depend on the patient and how long and why, okay? This is from Louis. What type of ceramic would you use to mask a dark and discoloured stump? The best ceramic to mask anything is going to be feldspathic. Feldspathic, because you can layer it, you can have intense opaque that's very thin. And then you can have, still have translucent layers and so on. So if you're trying to mask really dark stumps, I would do that. If you need a lot of strength, then it starts to get difficult. Sometimes I just go back to porcelain fused to metal because you get a lot of strength and you know that you have to block all the colour. Zirconia can be tricky. The key with blocking colour is you want to block the colour as far from the surface of the crown as possible or far from the veneer. So quite often, if I'm going to do something like zirconia or e.max, I will sandblast the core of the tooth and then I will do a core build-up with opaque resin blocking the colour, and then the crown actually doesn't have to do any of the blocking. The blocking's already done. So the deeper you get the blocking done, the better. If you're doing e.max, sometimes you've got to do a dual crown technique where you make a thin e.max, super opaque and very white, and then you do a second crown over the top in more translucent e.max, so the underlying crown is blocking the colour and so on. This is from Nadia. Would you say that shape trumps shade in most cases? The problem with that is it would make you suggest that you don't have to care about the shade. How about we give you a better idea? Just pay as much attention to the shape as you do to the shade, or vice versa, okay? There is no part of this that you can relax. The length is important. The shade is important. The stump shade is important. The planning is important. Your initial impressions done in silicon are important. Having really crisp impressions, everything. I'll give you a little example. When we built a house, we have a little row of 3 layers of bricks around the base of the house. It goes all the way around, and then there's wood above that. The bricklayer who was doing it, he took so much time getting everything so precise. And I'm going, this is a decorative feature, it's not structural. Why are you taking so long? He says, if I don't get this perfectly straight, then the boards above it are very difficult to get straight, and then the windows are hard to get straight, and then the boards above the windows are hard to get straight, and then the reinforcing for holding the roof on is difficult to get straight, and then it's difficult to get the roof straight. Everything from there up is difficult. So when you do these cases, there is not a single part that doesn't matter. Your initial impression must be crisp with beautiful gingival margins and not a big drag on the distal of the second molars. Because then your wax-up is crisp, and then your mock-up fits better, and then your crown lengthening is more precise. And then it's easier for the technician to get the crowns looking nice, and your gingivas are healthy, so you get easier impressions, and so on and so on forth. So I think that the idea that shape is more important than shade is wrong. Everything is important. There's not a single part of this that you can go, that's less important than the other thing. Okay. This is from Mark. If we have ceramics on the upper and composite on the lower, does the ceramic break the composite in the long term? No, it doesn't. It just wears it down. There you go. That was an easy question. Rennie, what would be the cause of sensitivity in the bonding protocol? Okay, this is a bit like shape and shade. Okay, I'm going to switch to the whiteboard because this is a complicated topic. Post-operative sensitivity with resin. So we're going to talk about we've got etch versus self-etch. So there's the first thing. Now self-etch I'm not going to use in an aesthetic area because self-etch stains. So most of the time I'm not going to use self-etching in it. If you use self-etching, it's more like, there are exceptions to this, okay? If you etch the enamel and then you use a self-etching primer and then a normal bond that's hydrophobic, then like SE Bond 2, the actual bonding material is quite hydrophobic, then you can avoid staining. But in general, we're going to have stain, okay? But with self-etching primers, we almost never ever get sensitivity. Sensitivity tends to occur here. Okay, so what's causing sensitivity? Oh, look, I could probably talk for about half an hour, okay, but I'll just give you a few. Etching too long. Etching too long. I'm hopeless at writing because I mostly type now. Teeth dry. I don't mean not contaminated, but if the tooth is dry, what happens is you etch and then you remove all the mineral around the collagen fibres in the dentine. Those collagen fibres are sitting up there nice and full of water, and then you dry them, they collapse and they trap air, and then when you put the bonding agent can't infiltrate under the collagen fibres, so you have air trapped there, and then you will bond, and then the patient will go, it hurts when I bite. And then you will adjust the occlusion, hoping to make it go away, but it won't, and then instead of cutting the composite out like you should and doing it again, you'll go, oh, you need endo, I'm sorry, okay? So too dry. I have teeth quite wet when I put the bonding agent on. I put a lot of bonding agent, a lot of primer to disperse the water, and then I dry. And I put more primer to make sure, and then I dry. And okay, next one is be gentle when you dry. Okay, when you dry the primer, what you're trying to do is evaporate the solvent and leave the resin behind. So you've got this solvent, it's usually alcohol, mixed with the resin. Okay, you put it in around the collagen fibres which are wet. the alcohol is miscible with water, and so it takes the resin in, helps it infiltrate underneath or displace or disperse the water out from there. Okay, but if you put your triple syringe right down and go bang and hit it with high pressure air, it's going to lift all of that primer off the tooth and just leave it with nothing. So there'll be no primer left. So your job with blowing air on a tooth is to blow it gently, to gently evaporate the water, gently evaporate the solvent, and leave the resin where it has infiltrated through the collagen fibres. So gentle drying, okay? And then you get into all the things like the configuration. But these ones, if it's posterior teeth, use self-etching primer. Don't etch the dentine, and then your sensitivity will go away. Don't etch too long. Don't have your tooth dry when you put it in. I know these go, oh, have it a time. I actually have my teeth quite wet, okay? Some people say that's wrong. I just put more primer and then I put 2 lots. I use Optibond Solo, so it's got the primer built in, but I put 2 brushfuls on a tooth right in the middle, and you can watch it disperse out over the tooth. You don't have to swizzle it around, just right in the middle, 1 brushful, 2nd brushful, it's just spreading out over the tooth, displacing the water. All the resin is going in there, and then I'm going to dry it real gentle, okay? So I don't go right down, and I start about 5 centimetres away and slowly bring the air closer so that we're drying real gentle and evaporating. And then I'll put a 2nd layer just to make sure that I've fully infiltrated those collagen fibres. Those 2 things there are really important. Okay. I don't know, I could go on for another hour on how to avoid sensitivity, but I won't because that's not what this lecture's about. Right. This is from Colin. If you restore worn dentition in a patient with excursive wear, i.e. the top and bottom wear facets match, will they continue to wear the restorations in the same manner? Yes. They will wear and break your restorations in the same manner that they wore or broke their natural teeth. The wear pattern will continue. So what you need to do is, first of all, you try and slow that down, okay? You're going to try and make it more round. You're going to try and make the material stronger. Maybe you'll do monolithic instead of layered porcelain. Okay, whatever you need to do to try and slow that wear down, okay? But it will continue. So warn the patient, look, you've worn your natural teeth down, okay? Think about surgeons, okay? If you get a hip replacement, does the surgeon say, oh, your hip's going to last the rest of your life because I'm desperate to sell you a hip replacement? No, he goes, it will last 10 years and then you'll need to get it done again, and you can only have it done twice. So if you're 50 and you get your first one, by the time you're 70, your hip's going to be ruined, okay? That's just how it is. They don't go, oh yeah, I tell them like 50 years so I can sell more of them. No, they get in trouble for that and it's dishonest. So if they have worn teeth, they will continue to wear everything else exactly the same way they wore everything else in the past. From Ahmed, how can I prevent open contacts in cases with non-receded interdental papillas? I think that will be difficult to slide the plastic instrument in the interdental area. I don't understand that question. So, if you wrote that question, try and write it to me again and I'll answer it some other time. Or send me a private message on Facebook and I'll try and answer it directly. Okay. Amit, is a mock-up a good way to learn for those of us just starting? It depends what you're trying to learn, okay? Mock-ups are a great way for learning how to... Actually, I'll tell you a better thing to learn. If you don't really know much about the shape of teeth, go and do a waxing course that technicians do, or a waxing course for dentists, okay? Learning to wax teeth, or alternatively, go and do a really high-level composite resin course, because one of the difficulties that a lot of dentists have with aesthetic dentistry is they don't understand what teeth actually look like. They don't understand like the mesial embrasure is less round than the distal embrasure on almost every front tooth. So, you know, your mesial of your central incisor is more square than the distal. The mesial of your lateral incisor is more square than the distal. The mesial of the canine is more square than the distal. So little things like that, that the long axis of your teeth gets more tilted as you go further around. So your central incisors are more straight, your lateral is a little bit more tilted, things like this. So these are crucial areas. In our hands-on anterior course, which is unfortunately sold out, this year was sold out last October, we make people build 6 front teeth from composite resin from scratch, so basically cut their model down and then build up the 6 front teeth, and then we make them do it again, okay? We make them do that because the shape of teeth is super important. So even though I said earlier that shape doesn't matter more than shade, if you can't do shape, then it's going to look terrible. Most of us can choose shades easily because we can easily know A1, A2, A3, okay, that's not very difficult, but the shape actually takes experience, training, and a lot of practice. This one's from Priya. What tips do you suggest for keeping temps on? Okay, I just ran the 3rd module of a live patient full mouth rehabilitation course. So these are dentists who come to my office, they treat a full mouth rehabilitation case under supervision. There's 3 modules. The first module, they prep all the teeth, and then they, say all the upper teeth, and they put temporaries on. The second module, they take the temporaries off and refine and take the final impression. And the 3rd module, if everything's going well, they take the temporaries off and they put the final crowns in, or they retake the impression if they had problems, and they come back a 4th time. I asked them, what's the most difficult part? They said the temporaries. The most difficult part of restorative dentistry is the temporaries. It takes a lot of time. Now, when you're less experienced, you take so long to prep the teeth, you're really exhausted by the time you start doing the temporaries, and you go, oh, anything will do. And I know this because that's what I used to do. Now, I was talking to a dentist once called Michael Mandkos, very, very talented prosthodontist, taught me when I was at dental school, still one of the people I look up to. Occasionally I see a patient of his come in through the door and the work's still beautiful, even if it's 10 or 15 years old. Great guy. And I talked to him one time and I said, how much faster have you got with experience? He says, I haven't. I just got better. He takes the same amount of time to do stuff as he did years ago, but he does it much better. So as your speed with preps and things increases, your time to do temporaries increases. That's why your temporaries generally tend to get better as you get more experience, because you finish the less important parts of the procedure quickly and you can spend more time on the temporaries. So number one, temporaries take a lot of time. They need adjustment. Often you've got to bulk them up where they're too thin, and then you've got to trim them and polish them and glaze them. They take a lot of time. So if they fit really well, they'll stay on better. If they're too thin, they won't stay on. If they're really thin and they're for a bonded restoration, then you have to kind of bond them on. So that doesn't mean full bonding, but it means if there's enamel, you need to spot etch the enamel and use some type of plain adhesive or flowable to hold them on. Or if you can't do that, just quickly swizzle some self-etching primer over the tooth, just very quickly, okay? Don't give it the full 20 seconds. Dry it off and a little bit of bond, and then cura your, say, bisacryl on. So quite often I will actually sort of semi-bond my temporaries where I really don't want them to come off. Lucas, do you always use cementing rather than bonding if minimal enamel remaining? No. I don't always use cementing rather than bonding. So I have done full rehabs where there was no enamel and I've bonded everything. Bonding agents lose their strength if they're bonded, particularly if they're bonded to a dentine, but they still lose their strength. Everything loses its strength. So if you have a case with really good resistance form, then you can bond all over the place. So anyway, it depends on the case. My number one rule for cementing is that the case is too close to the gingiva to get good isolation. So if I'm in an area where I can't isolate easily, then I'm going to get, I am going to tend to lean towards cementing rather than bonding. What would cause chipping of 1-1 and 2-1 in a young patient? Usually it's because the 1-1 and 2-1 are longer than their other front teeth and they do a protrusive parafunction. So during the night they slide forward onto their front teeth only and then they get chipping, okay? It could also be trauma, as in they tap up and down, or they've chipped it that way, but that's the number one cause would be just they protrude onto the front teeth. Or even worse is when their teeth are rotated and then they're going to bang one corner. So if the tooth is rotated, then say that their mesial is rotated in, then they're going to chip the mesial. And now it could also be fingernail chewing and things like that, but mostly it's just going to be the way they parafunction. This is from David. Can you please explain the bonded versus cemented crown on the short tooth with a lack of palatal enamel and your rationale for deciding between them? Okay, if the tooth doesn't have enough structure, bonding is not going to hold the crown on, particularly a front tooth, because front teeth have much more lateral forces. So front teeth, we tend to bite on the back and push them forward, whereas molars, we tend to bite vertical. So on front teeth, we get a lot of lateral force. You need enough palatal tooth structure. So bonding versus cementing is going to depend on whether I can get isolation, what sort of material I want. So say I really want to use e.max because I think it'll look nicer, or I really want to use lithium disilicate because it will look nicer, then I'm going to bond because that material needs bonding. But on the short crown, that's really it. If I've got resistance form, then I don't mind which material. If I don't have resistance form, I probably shouldn't be bonding anyway. If I have enough structure to bond, I probably have enough structure to cement, so it's going to come down to isolation and material. If I don't want to use zirconia or PFM, I'm more likely to bond. If I am going to use e.max or feldspathic, then I have to bond, okay? So now, Tram, would you avoid pulp exposure by leaving deep caries and continue to build up the core and then prepare for a crown? When I'm doing cases that are uncertain like that, I'm going to put the patient in a long-term provisional. So I will excavate the caries, do a core build-up, making sure that that core build-up is very sound. And then, now, when we leave a bit of caries, when you're inexperienced, you tend to leave a lot of caries. So when someone says, I left a little bit of caries, often that means a lot if you've just graduated, whereas when you're more experienced, leaving some caries means just the tiniest amount. If there is no sign of periapical pathology, there's no on the cone beam, and there is no symptoms, then I'm not going to go and try and expose the pulp. I find that if you do a nice core build-up very quickly and have good temporaries, you very, very, very rarely get problems with your crowns getting sensitivity or needing root canal therapy later, except in cases of cracks. So is it better to do RCT from a start even if the tooth is vital? No. Okay. There are some countries, it used to be believed in the past that there's so many teeth got root canal therapy from having crowns that you just did root canals on all of them. That is not true. Teeth don't get root canal therapy from doing a crown prep. They get root canal therapy from having the pulp exposed, or actually from bacterial endotoxin reaching the pulp in large levels, which usually means an exposure or a crack. So unless you physically expose the pulp with caries or with your drill, or there's a crack, then the pulps very rarely die, okay, the trauma. So a lot of people worry about root canal therapy. But if you follow protocols really well, you have good cores, you have good temporaries, you follow all that, then your root canal rate should be less than 2%, maybe 1%. Okay, I have hundreds and hundreds and hundreds of crowns with long follow-ups with OPGs, and the rate that you get root canal therapy if you do things correctly is very low. This is from Andrea. Are there any contraindications for opening the vertical? Any warning signs to patients who can't tolerate? Okay, I did a whole hour and a half on vertical dimension recently. You can find the lecture on the Academy. I'm not sure if the vertical dimension is in the free bit or in the bit that you have to pay for, but anyway, there's a whole section. I can't cover all of that. All I can tell you is that vertical dimension is very well tolerated by almost everyone. So you can jack the vertical dimension as much as will look good and is restoratively convenient, and very few patients will have problems. And in any case where you're changing vertical dimension, you're going to put them in temporaries or a mock-up first, so you get to try it out. If they don't like it, then you can change it. This is from Jose. Would you prefer to do a bridge in the anterior region over an implant? Okay, that's an impossible question. That's like saying, do you like cars more than aeroplanes? Well, it depends, okay? If you're flying to another country, then I don't like cars at all. If I'm driving around town, then I hate aeroplanes. So it would depend. I like bridges a lot more than I used to. So when I learnt to do implants, I hated bridges, okay? Bridges were evil. We used to tell the patient, that, you know, the If I do a bridge and one tooth fails, then you lose the whole 3 teeth and it's a catastrophe, and that's why you should have an implant. But then later on, I realised that when an implant fails, okay, first of all, implants take a long time. You have to do often a bone graft, and then you have to do the implant, and then a soft tissue management, and then temporary, and then impression, and get it made. So often it might be 3 months, 6 months, even 9, 12 months sometimes. Whereas a bridge may well be done in 1 month. It's very difficult to get an infection up into your sinus and have all your sinus lift blow out into the mouth, and then you can never do another sinus lift again easily if you do a bridge. So, you know, some of our procedures. So there are many cases. Anterior cases where you have missing laterals or young patients. I don't want implants in those patients because they get maxillary downgrowth, okay, and they get massive, the implant stays exactly where you leave them, and the teeth downgrow, and you end up with these implant crowns that are way, way up, okay? Now remember that maxillary downgrowth occurs throughout your entire life. I try not to put implants in the anterior before people are about 25, 28. I used to think 21, but one of the people who works for me, her husband's got one of the first implants I did, which I did when he was 21, and it's short, okay? It's short like a mill. That's one of the better cases, but some cases get much worse. Cantilever bridges are great because they don't lock two. When you lock 2 teeth together, it kind of acts like an implant. So you can get the same problems with downgrowth with a bridge that you get with an implant, as in the bridge doesn't move the same as all the other teeth. So either the other teeth splay or move forward or move down, and the bridge doesn't. So over the long term, if you can have single units or cantilevered bridges, it generally will look better for longer than if you have splintered teeth. Do you issue a splint in all these cases? Yes. If I don't quote a splint, I give them one for free. This is from John. How is occlusal vertical dimension determined? I did a whole hour and a half on that previously. Go to the academy. There's like the occlusion and vertical dimension lecture. It goes for 6 or 7 hours. It's available, I think, on sale now. Yeah, it's available. You can go and have a look at that now. Okay. What planning software can we use? I use Keynote or PowerPoint. You just get like the draw tool, okay? They both have a draw tool. You can do like little things, and then usually I draw around one tooth, and then I duplicate it, Control D to duplicate it, and you flip it over and put it over the other tooth and then stretch it, and it takes you like 5 minutes to draw a whole bunch of teeth. How do you clean the glycerin off the veneers before bonding? That's actually a good question, because if you forget to do that, you will be very sad, okay? It's water soluble, so you wash it off, and then you're going to acid treat the veneers. So my veneers come from the lab with hydrofluoric acid, and they're silaned. If you want to do your own hydrofluoric, that's fine. But I always acid treat them to reacidify and to remove any salts and to remove any contamination before we resilinate and bond and so on. So it's going to come off from that. Here's another one from SS. Will glycerin affect bonding? No, not if you wash it off. It's water soluble. John, what type of occlusal scheme is used for these cases? I did a whole lecture on occlusion, so I won't try and cover that again. What options do you give for PEG laterals? What do you take into consideration before treatment? PEG laterals are pretty tricky. If you can do a like feather edge ceramic thing on PEG laterals, they last terrifically well. So even in feldspathic, because you essentially have 360 degrees of enamel and then you bond ceramic to it, they last amazingly. If you can't do that, composite resin on PEG laterals is very difficult. It's difficult to get the emergence profile right. So if possible, do ceramics. This is from Vipin. Any tips for laminates and veneers for newcomers? Do some training. That's my tip. Or learn what not to do the same way I did by cutting off your own cases 1 week later. It's much cheaper to do training, but if you like to do things in an expensive and really painful and miserable and soul-destroying way, then do what I did, which is do big cases when you're not really that well trained and then cut them off. Okay, now this is from Anonymous. How do you know what the maximum size or length could be? A longer incisal length may look more aesthetic, but may have undesirable guidance on occlusion. So basically decide what looks good and then work out how you're going to make the function work. Okay? If it's too dangerous, then have a discussion with the patient whether they want to look good or want their teeth to last, because they might not be able to have both. How would you match shade precisely in a case of a single anterior veneer? So here's how you match precisely in a single anterior. You take all of the shade photos you normally do, but you quote the patient a little bit extra, maybe 25% extra, because you're going to send all the stuff off to the lab. The lab's going to send it all to you. You're going to try it in and go, no, it looks terrible, and take a whole bunch more photos, then send it back to the lab, and then the second time it'll probably look good. So don't pretend you're going to get a single unit of anything to look good in your first try, okay? Single units are very difficult. Expect that you will need to do 2, at least 1 try. And that's why good labs often charge more for single units, because they know that they're going to do a try-in, okay? And you should also charge more for single units. This is from SS. Do you use Gloomer desensitizer for sensitivity? I used to, but I don't anymore. This is from Jamin Huang. Lincoln, could you go through how you manage a case when a patient comes in with deep caries, which is asymptomatic, but risk of root canal therapy from a clinical discussion consent? So if you think, when you're doing a big case in particular, if you think there's a risk of root canal therapy, add it to the quote, because it's very easy to say to the patient, hey, we thought we needed to do root canal therapy, but it turns out we didn't, which is great because I think it's boring and so do you, okay? And you get to save some money. So if in doubt, you can add it into the treatment plan and then take it out. So in my big cases, I go, that tooth looks a bit odd, that one looks a bit odd, that one. So it's kind of like Oprah, you get a root canal, you get a root canal, everyone gets a root canal. So I would just put in root canals on any tooth that looks a bit suspicious, but quite often I get to the end of the treatment plan and I haven't actually done all those root canals, or sometimes never done any of them. So imagine, I do that, I get to the end, the patient, I go, look, I don't think you need those root canals. I'm going to keep them in your treatment plan just in case they turn up next year. But it looks like you just saved $6,000 on what you thought. And you didn't have to have some dreaded root canals. How do you feel? And the patient goes, that's terrific. I was expecting the worst and it's even better. Okay? Or if it goes wrong, you go, look, I said you'd need 6, but you only needed 5. Great. Okay? But now I'll give you the other scenario. You go, oh, I don't want to tell about the root canals. Okay? And so you don't. And now you do a crown, nice new crown, beautiful occlusal anatomy with some lovely tinting. The technician has slaved over it. And the patient comes back and goes, it's hurting when I have a hot drink. And what are you going to do? You're going to adjust the occlusion, because we all adjust the occlusion hoping that all sorts of toothaches go away, and they never do. Okay, and then they go, oh, now it's aching to hot for 1 hour after I have a hot drink. You know, your time's up. Okay, and then you drill a great hole right through all that beautiful tinting of the fissures, destroying it all, and feeling sad inside your heart. Okay, and worse than that, the patient thinks you're a terrible dentist because he did a crown on my tooth and caused a root canal. It wasn't you that caused the root canal, it was a root canal just waiting to happen. Okay, I tell the patients it's like this. You've got a beehive in your garden. I go in there and I start pruning all the garden. The next thing is there are bees going everywhere stinging me. I didn't cause the bees by pruning the garden. The bees were already there, I just stirred them up. When you do a crown, you don't, unless you mess the bonding and cementing up, when you do a crown, or your crown prep so deep that you expose the pulp, so there is the possibility for incompetence here, but when you do a crown, you don't cause the root canal therapy. The root canal therapy is already in the tooth waiting to happen, you just stir it up. Instead of happening in 6 months, it's going to happen now. So that's how I warn the patient about that. Okay. If you've got any more questions, send them in. I'm running out of questions now, and obviously if you haven't seen the link already, the anterior course is on sale now, and Gail will have given you some links for some special resources for waiting right till the end, so thank you so much for that. This is Lillian. Could you create space for missing lateral incisor for implant by closing the midline diastema between 1.1 and 2.2? Can you create space for a missing lateral incisor for an implant by closing the midline diastema. I think it means between the 1-1 and the 2-1. Yes, of course you can. As long as there's not a massive, great frenum going between those two front teeth, because you've got a massive frenum, you'll close those teeth and you'll put your implants and then it'll go boing and it'll push everything out the other side. Okay, so you can't close a diastema without removing the frenum. And when I remove the frenum, I dissect it right down to the bone. You don't have to do a big dissection. It only needs to be narrow, but it needs to go right down to the bone. Pull the teeth together, and yes, that would help if you're getting to have enough space. It would depend on how much space you need. Here's one's from Jamin Huang again. With the previous question, what would you do if the patient says they can afford a filling but not root canal therapy if it requires it in a tooth with deep caries? Well, I'd tell the patient, if I do a filling, you may need root canal therapy. If you can't afford to do that, then maybe don't do the filling, get an extraction. Okay? If the patient can't afford complications that could be expected from your procedure, don't do the procedure. It's like saying, the patient says, I can afford to have the veneers done, but I can never afford for any of them to break. Don't do the veneers. I can afford to have the implant done, but I can't possibly afford to have the gums fixed if I get recession in 5 years. Don't do the implant. It is better to not do something and never take the patient's money than to do something, take their money, and then have to give it back. Okay? But you may have to learn that yourself. This one's from Vikram. What's your experience with resin bonded bridges, with Ribond, Everstick, etc.? If you do a resin bonded bridge with fibres and you do it well and you check the occlusion and you have a big enough area bonding, they last for a really long, surprisingly long time. If you use a resin bonded bridge in a parafunctioner who's got all flat worn teeth and your connector is too small and you don't get all the plaque off the tooth and you don't check the occlusion and the bonded bridge is loaded all the time, it will break very quickly. So it's mostly in the occlusion, the size of the connector, how carefully you clean the tooth and make sure there's no plaque on it, and having fibres in there. And don't cut the connector too deep on both sides, only do it on the buckle so it looks nice. And I've run out of questions there, so thank you so much, those of you who've watched. And I hope you've enjoyed tonight's presentation on how to avoid some of these big nasty disasters with smile makeovers. And hopefully I can save you the pain of cutting off your own e.max. If you have to cut off your own e.max one day and you're feeling depressed, send me a message, okay? I'll try and cheer you up because I've been through it too. Please go and check out the full 12-hour video on all the stuff, which is both me and Alina Rusanova teaching. It's just, we wanted to make it available everywhere in the world and at a much lower cost than if you'd come to our event live. And you know, it's like way less expensive than if you'd come, not even including all of the flights and so on. And of course, if I can save you having to redo one crown, it will have paid for itself. One more question from Braden. What type of margin is preferential to avoid recession in patients with a thin biotype? Also retraction isolation methods which minimise chances of recession. Some people say vertical margin is better in recession-prone cases. I think the best thing in a patient prone to recession is a supragingival margin. So if your tooth is not dark, then keep the margin up supragingival and just stay away from the gingiva. Don't retract heavily. Don't use astringents on the buccal tissue. If you have a case where that's a really big issue, you want to temporise first. So prep subgingival, temporise, wait 6 weeks, then take your final impression with really good temporaries in place. And that way you can see what the tissue is going to do. If it's absolutely crucial, graft the tissue first so that it doesn't recede. Simple. How do you retract and isolate? Like, you don't want to use Brinker B4 clamps on super thin tissue. It's going to just, it's just going to cause recession. So, you know, you're going to use the type of retraction that's most gentle to the gums in these cases. If it's such a big issue that they're a thin biotype, change them to a thick biotype. Okay? Or warn the patient that they'll get recession. Okay? Don't make the patient's problem your problem. So the patient's problem is they have thin biotype and they could get recession. That's the patient's problem. If you want to take that problem away, you do grafting and then they don't have thin tissue anymore. Or you don't do anything. Or the patient accepts they could get recession. So don't get stuck in that false choice. Like recently, I'll give you an example. I recently had a patient come in wanting orthodontics, but she didn't want her teeth to look different. And I said, well, which one is it? You can see there's a trap there. She wants orthodontics to straighten her teeth, but she doesn't want them to look different. Well, that's impossible, okay? You have one or the other. So which one is it? Make your mind up. Oh, here's one from Ryan. Okay. As a student starting to do crowns and bridges, any tips or suggestions for further development outside of dental school? It depends where you are, Ryan. If you're in Europe or in the Australia Pacific region, obviously I run a course where we make you prep. Well, in one of my courses I make you do 28 crown preps in 2 days. And I do that not because I want you to be fast, because I want you to get the hand-eye coordination that only comes from a lot of repetition, going round and round and round the tooth, again and again. Otherwise, I would suggest you get your own model and practice doing lots of crown preps, okay? That is the key part. I've got quite a few resources on the Academy on just some tips on how to prep crowns and some cases where you can see me prepping lots of teeth and how I do it. Something will click at some point where you realise that crown, like I don't do all the depth cuts and then join them all up because you end up with these rough crowns that are very hard to get rid of, rough bumps. Things to focus on is this. Every step should be done perfectly before you move on to the next step. That's the number one thing to focus on with any procedure. So don't move on from the local anaesthetic until you've done so much anaesthesia that patient's never going to feel anything for the entire appointment. And then you can forget about it, you can dump it out of your brain and now focus on what's next. Okay, don't move on until you take a perfect pre-op impression. Dump that. Okay, so every step, do it properly. Take your time, do it slowly and carefully and properly, and then forget about it. Because when you don't do the first step properly, you go to the second step and then you've got to go back to the first step and then you get to the third step and you've got to go back to the second step and then back to the first step. So you know you don't do the anaesthetic properly, you're trying to put the rubber dam on, they're going, ow, it's hurting on the palatal tissue, okay? And so then the clamp doesn't sit down properly and then your dam doesn't seal and you've got fluid coming in and then the entire appointment's a mess and then they start to get pain again, okay? Do each step properly before you move on. That is the thing that you can focus on. Okay, this is going to be my last question because I am about to fall asleep. This is from Shoaib Durrani. I like how you put so much emphasis on understanding the psychology of our patients. Very important. What are the top 3 red flags for you in a middle-aged person looking for a revamped smile? It doesn't matter what age. So the top 3 flags. Number 1, depression. A patient with unstable depression will be a nightmare. This is, now, in the audience watching this, amongst dentists, there'll be a whole bunch of you have recession. I have, not recession, you'll have that too, because dentists don't fix their teeth. There'll be some of you who have depression, and I am not attacking people with depression. My brother-in-law has depression. Okay, I've got other family members with depression. I understand it. I understand a lot of their struggle with managing it. I also understand, and I've been told by close family members, that when they're in a depressed state, they don't make rational decisions, and I've had patients do that. Like I had a patient ask me to take out all her implants. I'd put them in like 4 months, they were all integrated, and then she just decided one day she wanted them out. And because I was young and inexperienced, I took them out. And then she said, now my dentures loose. I go, of course it's loose. The implants were there to hold it in. You asked me to take them out. And then she complained to the regulator and tried to get me into legal troubles. Okay, and that was when I realised it was only after I got to that point, I was somehow asking her questions. She said, yeah, you know, my depression's not been real good. And I said, it doesn't say depression on your medical history form or the medication you're taking. So quite recently I had a patient say, oh yeah, she had no medications on her list. I said, do you really not take any medications? Because she had a complex medical history. She had lupus and she had kidney problems and she had all this stuff. Oh yeah, I've got a great long, it's too long to write down for you. You're only a dentist. She wanted implants. She's on blood thinners, immunosuppressants. Could have died. So number 1, depression. Number 2, people telling you 2 different things at the same time. I want my teeth to be longer, but I don't want them to look different. Tell that patient to make their mind up about which one it is. And number 3, patient who wants a Rolls Royce for the price of a Toyota Corolla. Okay? People actually get more fussy as their budget gets smaller. Okay? Because every dollar becomes more precious to them as their budget is smaller. So the biggest red flag is actually not the patient, it's you, your eagerness. So the biggest red flag for dentistry is, do I want to do this treatment more than the patient does? And if you do, you'll be in trouble. So you can't do your best dentistry until you no longer care whether you do it or not. And that's probably the best advice I can give you on smile makeovers. So thank you so much for watching. I hope you've had a good time.